So we are going to talk on follicular dynamics today. And as you all know, it's all about morphological and vascular changes or the responses of the ovaries and the uterus to the hormonal changes which are occurring throughout the menstrual cycle. And therefore, a little bit of understanding about the hormonal changes and the exact response of the ovaries or at the status of the ovaries and the uterus at that stage would help us understand the monitoring more, especially for my all radiologist friends. Just a quick look at that. At the beginning of the cycle, as you can see there, there is almost no estrogen and progesterone, no FSH-LH, and then there are only small antral follicles, pre-antral follicles. Then the estrogen, the FSH level rises a little, the estrogen level starts rising, and then there's a selection of the follicle. Then at the start of LH surge, the follicle is already mature, and then at that stage the estrogen is fairly high. The estrogen level then falls suddenly with the rupture. At that stage, you can see the endometrial thickness is nearly the highest. With the start of progesterone, the endometrial thickness decreases a little, and then it again grows in the mid-luteal phase. So if we just keep this in mind, maybe we might be able to understand and remember the things that we are going to learn now a little better. Follicular dynamic study should start with the first or second day of the cycle, when the secondary antral follicles are only 2 mm at first. And then at that stage you can visualize them, or they may be even 1 mm and you will be able to visualize them. Population of the antral follicles rapidly increases during the menstruation that had drastically decreased during the luteal phase. So during the luteal phase, the population of the antral follicles have decreased, and they suddenly start growing as soon as the menstruation starts. Before day 5 of the cycle, the selection of the dominant follicle occurs, and between day 5 and 7, the dominance of the follicle becomes apparent even on ultrasound. The fate of the follicle as to which follicle is going to become atratic and which one is going to grow to dominant and rupture depends on 4 things: size, rate of growth, wall thickness, and internal echogenicity. But more I would depend on the rate of growth and the wall thickness. A follicle which grows at a continuously steady pace of say 1 to 2 millimeters per day is more likely to give you a better quality oocyte and get fertilized. A wall thickness thinner is better. So that's why the first scan should be planned between second and third day of the cycle, at second or third day of the cycle. And this is known as a baseline scan. A baseline scan because at this stage, the estrogen, progesterone, LH, FSH all are at the minimum level. Moreover, the ovaries would show only antral follicles, no follicle larger than 9 mm, and no active corpus luteum. Only then this is a silent ovary when the baseline scan is actually valid. The purpose of doing this baseline scan is to find out whether the ovary is a polycystic, a normal, or low response. But I'm not going to go into the details of that. Dr. Nick has explained us very beautifully about the PCO. Our main aim during follicular dynamics is to decide and plan our stimulation protocol. And this protocol can be decided based on 2 things. One is the ovarian reserve, and the second one is the ovarian response. I would like to differentiate these 2 things clearly, because the reserve means how many number of follicles you are going to get at the end of the stimulation. And therefore, that depends on the antral follicle count and the ovarian volume. And by response, we mean how much push it's going to require to get stimulated. That means what would be the doses required. And that should depend on the intra-ovarian flow. According to the literature, the assessment of the ovarian response, therefore, should be based on the antral follicle count, the ovarian and the stromal volume, the stromal FI, which is a 3D power Doppler index, the flow index, and the ovarian RI and PSV. The importance is in this order. All these factors, they do not get changed by a short-term treatment by GnRH agonist or agonist, that is pituitary downregulation, and therefore, even in IVF cycles, even once you have done a downregulation, they are fairly reliable and you can depend on them to decide your stimulation protocol. The number of antral follicles, of course, represents the functional ovarian reserve, and Dr. Nick is still going to talk a lot about it, the ovarian reserve and the sono-AVC. So I'm not going to go into much details of that, but I want to assure you that the studies have shown that AFC is at least as reliable as AMH, and this values he has already shown to you. Total AFC, if less than 10, it's known as a poor response. More than 10, between 10 and 20 is a normal response, and more than 23, it's risk for OHSS. Counting antral follicles is really important because, as shown in this study, the cancellation rate of the IVF cycles is pretty high when the antral follicle count was between 4 and 7, whereas it was pretty low as only 3% when the antral follicle count was more than 10. So it does make sense counting the antral follicles before taking a patient for IVF. Though, intercycle variability is more significant in young and especially those who have high AFC. That means the patients with PCO may have a considerable intercycle variability, and that would tell you as to how many follicles you are likely to get, how many mature follicles you are likely to get at the end of the stimulation. According to Dr. Nick's paper, you are likely to get about 60% of the follicles that you have counted on inversion mode as antral follicles at the end of the IVF stimulation. And of course, sono-AVC is a very, I would say, time-saving way of knowing the total number of antral follicles, especially when there are multiple. See, if they're between, say, up to 12, it's not a problem. 12 to 15, you can just scroll on a 2D and find out how many there are there. But especially in PCO patients, when there are multiple small follicles, you are likely to make mistakes. And it's always better to make a proper use of the technology. Ovarian volume of less than 3 cc was significantly predictive of higher IVF cancellation rates, and that was more than 50%. That was that means small ovaries, small ovarian volume, of course, means a low reserve or a low responsive ovary. It is interesting to know that the measurement of the ovarian stromal flow in early follicular phase is related to the subsequent ovarian response in IVF treatment. Not only 3D, but even if you can take a PSV, stromal PSV of the best flow vessel in the stroma after pituitary suppression, it can be predictive of an ovarian response and outcome in the IVF treatment. Kupasek has taken 3D power Dopplers volumes and found out the stromal FI, and has defined that if the stromal FI was less than 11, the patient would be categorized as a low responder, between 11 and 14 a good responder, and more than 15 would suggest a high risk of OHSS. And this can be done very easily on a volume histogram. It doesn't consume much time once you have taken your volume. Why thin-limb patients with hyperandrogenism are more likely to get OHSS can also be explained by this, because we know that PCO patients have high AFC and high stromal vascularization, but it's in hyperandrogenic females that the stromal vascularity is even high, as just now mentioned by Dr. Nick. But in obese patients, the vascularity is lower. That means thinner the patient, vascularity is more hirsute a patient, vascularity is going to be more, and therefore thin limb patients who are hirsutes are more likely to go into hyperstimulation syndrome. Whereas the patients who have endometriosis have significantly lower vascularity in the stroma. And how much is the vascularity in the stroma, and even in endometriotic patients, would help you decide what could be the prognosis, what could be the outcome of the IVF cycle. Thus, it's really, really important to look at the stromal flow on your baseline scans to decide your stimulation protocol. We, at our institute, we decide our stimulation protocols based on the AFC, the antral follicle count, the ovarian RI and PSV, the ovarian volume, and stromal FI. And the shortest and the sweetest protocol can be a higher doses of stimulation should be considered when the stromal RI is more than 0.7, stromal PSV less than 5, stromal FI less than 11, AFC less than 3, ovarian volume less than 3, and the patient is obese. Whereas you should be very, very particular in selecting the dose of stimulation when the RI is less than 0.5, stromal PSV more than 10, stromal FI more than 15, AFC more than 12, and when I mean AFC, it's FNPO, that is follicular number per ovary, and ovarian volume more than 8 cc. Of course, you may have combinations from both the tables, and then you have to balance your dose calculations. Endometrial assessment also must be done on day 2. And you look at an intact endomyojunction. The junctional zone has been beautifully shown by Dr. Nick. And the normal shape of the endometrium that rules out any subendometrial lesions which would come in the way of implantation. And there should be no vascularity seen in the endometrium at this stage because the estrogen and progesterone are both at minimal levels, which are both the hormones which are responsible for both the follicular and the endometrial vascularity. If at all you find flow in the subendometrium at this stage, that means it's pathological. It is most likely some inflammatory process going on or some invasive process like adenomyosis. Now, coming to the 5th or the 7th day of the cycle, the dominant follicle the selection of the follicle has already been occurred, and the dominant follicle now starts growing. As it starts growing, it stops or it prevents the other follicles surrounding it to develop. That means it pushes everybody outside. Come on, I am the boss and I'm going to grow. You move outside. And it is interesting to know that it's not often the first largest follicle that you see may be a dominant follicle. Then how do you know that which one is going to be the dominant follicle? It's 2 things. Number 1, there's an increase in size in this follicle. Moreover, there is increase in the granulosa cell thickness over there. Along with that, as the follicle progresses towards dominance, there is also increase in vascularity. We go to the Doppler after this. A follicle which is more than 12 millimeter can be considered as dominant. It grows at the rate of 2 to 3 millimeters or say 1 to 2 millimeters a day. Ovulation naturally occurs when the follicular size is between 18 and 24. This is what all of us know. What we miss to see in our hurried practice is that there is a sonolucent halo that appears surrounding the follicle just about 24 hours before ovulation. A cumulus-like shadow may be seen 36 hours before ovulation, and the closest to the ovulation, before 6 to 10 hours, you'll actually see the separation and folding of the follicular lining. Coming to the Doppler, the vascularity starts the follicle starts pulling the vessels towards it about 8th day of the cycle, when the dominance has already been established. But the flow keeps on increasing, though the RI, the resistance, starts decreasing only 2 days prior to ovulation. That means if you are following a follicle and you are doing a Doppler also, if the RI starts falling, that should just give you an indication that the ovulation is now close, may occur in 2 days or so. The resistance remains low for 4 days and then gradually rises to reach about RI of 0.5 by the mid-luteal phase. The ovarian flow correlates well with the oocyte recovery rates, and therefore, before giving HCG, Dopplers should be done. The vascularity then should cover about 3/4 of the circumference of the follicle, and the RI should be less than 0.48 and PSV more than 10 centimeters per second. Follicular RI and PSV are both very important for the decision making rather than just the size of the follicle. If the size of the follicle is okay and still the RI and the PSV, that means the vascular indices, are not satisfactory, you may still wait, don't worry for the rupture, and allow this indices to come to normal to get better results. This is because oocyte, it has been shown in a study produced in Human Reproduction by one, that oocytes from severely hypoxic follicles are associated with high frequency of abnormalities of organization of the chromosomes on metaphase spindle and may lead to segregation disorders and catastrophic mosaics in the embryo. Another study has also shown a similar finding, that a fertilization of a follicle with a PSV of less than 10 centimeters per second have high chances of developing embryos with chromosomal abnormalities. Now, when you are doing some intervention, you want a result, you want a pregnancy, but you don't want an abnormal pregnancy. So that's the reason you must wait till the PSV reaches 10. A study by Nargund et al. Has also shown that when the PSV of the follicle was more than 10 centimeters per second, the chances of getting grade 1 and 2 embryos was 75%, whereas it was only 40%, that means only the half, when the PSV was less than 10, and only 24% when one could not detect any perifollicular flow. Now, just prior to ovulation, due to the penetration of the vessels into the granulosa cell layers, there is an increase in the PSV. That means there's first a fall in RI just 2 days before, that's about 48 hours before ovulation, and now just before 29 hours, that means you are progressing towards a rupture. Before 29 hours, the PSV starts rising, and it continues to rise at least 72 hours after ovulation. That means when the LH surge has started, the PSV was 10 centimeters per second with a normal RI less than 0.48 or roughly say 0.5. Now when the LH surge is at its peak, that means when the rupture occurs, it is 45 centimeters per second. Therefore, a rising PSV with a steady or low RI is a sign of an impending rupture. Whereas the contrary, if the PSV is steady or decreasing and the RI is rising, this is a sign that this follicle is not going to rupture. It's going to go towards a luteinized unruptured follicle. Now, based on this concept, we did a study to find out that when the PSV of the follicle was high, say not 10 but 15, 20, 25, when we did a scan before giving an HCG, in these cases, we assume that the follicle is going to rupture early, and therefore, would an early IUI help us? And this study clearly showed that whatever the stimulation protocol, when the PSV of the follicle pre-HCG was between 20 and 25, the yellow bar, which shows the double IUI, has given definitely increased pregnancy rates, and this double IUI was scheduled, first one 12 to 14 hours, and the second one is a scheduled time 34 to 36 hours after giving HCG. This means that the earlier IUI has definitely helped us to give pregnancy in these patients. Therefore, whenever the PSV is more than 20, when you are doing your pre-HCG scan, we would recommend that, with a normal RI, we would recommend that you do an IUI earlier rather than the scheduled time. We also do a volume assessment of the follicle, looking at the follicular volume, cumulus, and the perifollicular flow on 3D power Dopplers. And the follicular volumes especially have been known to be much more reliable than the diameter when there's a polyfollicular development, of course, because they become all polygonal because of the pressing by other follicles. And a follicular volume of between 3 and 7 has been known to be optimum for the oocyte retrieval. Cumulus, I don't know. There have always been controversies, but we have been able to see cumulus by 3D on at least 85 to 90% of cases with mature follicles. And that is the surest sign that it contains a fertilizable ovum. Follicles with more uniform perifollicular vascular network are more likely to produce pregnancy. That means they are more likely to give you better quality oocytes. And therefore, even a subjective picture of the follicular vascularity would help you assess better the oocyte quality that you are going to get. But we have also found out quantitative values for this, and our values, which is says that the follicular volume of between 3 and 7.5, VI of between 6 and 20, and FI of more than 35 would be very helpful to increase your pregnancy rates apart from your 2D and the color Doppler parameters. And this was based on a study of more than 1,000 cycles. And here you can see the results of this study, wherein all the patients selected had normal or optimum 2D and color Doppler parameters, but the pregnancy was achieved only in the patients with the pink bar, wherein the values of the follicular VI was between 6 and 20, and of course the follicular FI was between 27 and 30, more than 27. Assessing the endometrial receptivity again, we go back to our cycle understanding. During the natural cycle, there's an increase in the thickness of the endometrium of 1 to 2 millimeter daily during the proliferative phase. It starts becoming triple line 6 days from before the LH surge. That means as soon as the dominance of the follicle is decided, the endometrium starts becoming triple line. And it remains so 7 days after the LH surge also. It decreases in thickness 0.5 mm on the day of LH surge. That is because of sudden fall in the estrogen level when the progesterone has still not reached its peak. And then there's a further increase of 2 millimeters during the luteal phase. It is important to know that the endometrial peristalsis now detected, that means after the 7th day of the cycle, 7th to 8th day of the cycle, when the dominance of the follicle has already been decided, is in the cervicofundal direction rather than the other way around in the earlier phase of the menstruation. The endometrial changes, though, during the stimulated cycles are little different. In the CC cycle, it is faster in the later phase of the proliferation. You know that is because of sudden withdrawal of the anti-estrogenic effect of CC. CC we usually give from 5 to 9 days, and as soon as that is withdrawn, the anti-estrogenic effect starts falling, and therefore the endometrium starts growing at a faster pace. In HMG and FSH cycles, the endometrial thickness is more than in the spontaneous cycle. This is very interesting that when we go to the Dopplers, we'll see that though the thickness is more, the vascularity is not as much in the stimulated cycles as in the natural cycles. Along with the increase in the endometrial thickness, there is also slight increase in the length of the endometrial cavity at this stage, and this has been shown only in one study. Now, we know that the follicle has already been matured, and therefore the endometrium has to be fairly endometrium should have a good receptivity. So how do we grade the receptivity of the endometrium? Even on 2D, a multi-layered endometrium, we all know, is a very good endometrium, but a multi-layered with internal echogenicity, which is at least as echogenic. The internal echogenicity, which is at least as echogenic as the anterior myometrium, is a very good endometrium, and according to Smith et al., that is a grade A endometrium, best for implantation. The echogenicity is because of the multiple blood vessels which are penetrating it, giving multiple tissue interfaces, and also because of the storage of the glycogen in the columnar cells. Grade B is the one which is multi-layered but hypoechoic in between, and grade C is, of course, the homogeneous isoechoic endometrium, which is often seen in the PCO patients. Nearly the same time as the follicular vascularity, the spiral arteries also start extending towards the endometrium. And this is the pure effect of rising estrogen. Endometrium and the subendometrial flow increases in the follicular phase and reaches its maximum 3 days prior to ovulation. That means the endometrial vascularity has grown even before the follicle has reached its maximum vascularity. Fall in the vascular indices after ovulation are due to vasodilatation of the subendometrial capillary plexus and ultimately the stromal edema that are essential for the embryo implantation. Now, if we know the vascularity has to develop, we have to grade the vascularity also. And the zones of vascularity have been described as zone 1 when it reaches the endomyojunction, zone 2 when it touches the outer echogenic line, zone 3 when it comes to the intervening area, and zone 4 when it touches the central line. Absent subendometrial and endometrial vascularization on the day of HCG appears to be a very useful indicator for implantation. And the studies have shown that the pregnancy rates are much higher when the vascularity was shown in zone 3 and 4 as compared to when the vascularity was seen only in zone 1 and 2. Endometrial neoangiogenesis is different in natural and stimulated cycles, as I mentioned earlier also, and the vascularization is approximately 35% less in the stimulated cycles, as I told you. Endometrial and subendometrial vascularization may serve as a prognostic marker for the ongoing pregnancy also. And it has been shown in a study by Chen and et al. That when a pregnancy is achieved in absence of the endometrial and subendometrial flow on the day of embryo transfer, more than half of these pregnancies will end up into a spontaneous miscarriage. Therefore, it's very important we do check whether the subendometrial and endometrial blood flow are present or not. These blood vessels then have to have a RI of less than 0.6. That is important. That means they have to be moderate resistance blood vessels. Moreover, it's also important to assess the uterine artery at that stage. Now, normally in the cycle, till day 13, uterine artery is a high resistance vessel, which has an RI of as high as 0.88. But it reaches a nadir close to ovulation, and then by day 16, it's again 0.84. The uterine artery PI and at the time of HCG should be less than 3.2 and the RI less than 0.8. Now, it's important to look at the uterine artery indices also, because an endometrium flow ultimately depends on the uterine artery flow, and if there is a very low flow or absent flow in the diastolic phase during the diastolic phase, that means the endometrium is not going to get its blood supply during the diastolic phase, and therefore the oxygenation is going to be affected, which would ultimately not help implantation. These studies must be done on the day of HCG before giving HCG, because once you give HCG, there is a fall in the estrogen level. The progesterone is not yet raised, and therefore there would be high resistance in all the uterine vessels, including the spiral ones. And the same phenomenon is also seen in the natural cycle. So, if we sum up, a follicle which is at least 18 millimeter, with covering the vascularity covering 3/4 of the circumference, with an RI of less than 0.4, PSV more than 10, would be good, with good global vascularity of the follicle and the cumulus. The endometrium, which is grade A or B, at least 8 millimeters, with good endomyojunction and a normal endometrial shape, vascularity reaching zone 3 and 4, which should cover at least 5 millimeter square area that has been mentioned in one of the studies. That means it should not be only one vessel that should reach the endometrium, the inner layers of the endometrium. That should be at least 5, 6, 7 vessels from one side which are entering the endometrium, and that should be a good endometrial vascularity. And of course, the endometrial, the uterine artery PI should not be more than 3.2. We also do 3D power Doppler studies for the endometrium, and the same study that has been mentioned earlier gives the values, but you can see that is a half-cut endometrium, and you can beautifully see the blood vessels reaching right the inner layers of the endometrium here. So even subjectively, you know that the endometrium has very good vascularity, and those are the values with FI more than 40 and VFI more than 20 for a good endometrial receptivity. Like the follicle, the endometrial receptivity also improves when you include these parameters, and that has been shown in several other studies also, that more vascularity in the endometrium, volume between 3 and 7 of the endometrium, are going to be helpful predictors for implantation. Of course, the endometrial vascularity is pretty low when the patient has either hyperprolactinemia, chronic endometritis, endometriosis, or Escherman syndromes, as you all know. It's important to look at the secretory phase also, because you know it's in this phase when the progesterone level is almost at its peak. It has been remained high for quite a long time. That means the endometrium has grown to its maximum, and the endometrial vascularity is fairly good. Beyond this point, the endometrial vascularity is going to decrease because we know the progesterone level is going to fall there. Then the endometrial vascularity decreases until day 5. So the initial phase, it is low. If you see the initial secretory phase, it is low, endometrial vascularity, because the progesterone is low. In the mid-luteal phase, it's high, and then it again decreases. The flow continues to increase during the menstrual phase also. Now, at this stage, though the estrogen progesterone have been withdrawn, it's because of the shrinking of the endometrium, which brings the vessels together, and it gives a false feeling that the endometrial vascularity is still there. In the secretory phase, normally, the progesterone, the corpus luteal vascularity is very good, and there's a clear correlation seen between the RI of the corpus luteum and the plasma progesterone levels in natural cycles. It can therefore be used. That means the RI of the corpus luteum vascularity, can be used as an adjunct to the plasma progesterone assays to assess the luteal function. And at this stage, in normal cycles, the RI of the corpus luteum should be less than 0.5. And the spiral artery RI, now again, at this stage also, the blood vessels are still approaching the endometrium, and the spiral artery RI should be less than 0.5. Again, 0.52, but roughly you can say 0.5. And at this stage, the uterine artery resistance is at its lowest, should be PI should be less than 2.5. Segmental uterine and ovarian artery perfusion demonstrate a significant correlation with the histological and hormonal markers of the uterine receptivity, and may add in assessment of the luteal phase defects also. We know about 2 luteal phase defects. One is the luteinized unruptured follicle, which if we are doing the follicular monitoring right from the beginning, we can predict with higher RI and lowering PSV. But if we are seeing this patient directly into the mid-luteal phase, we can, or we are doing a follow-up and we want to confirm, it can be confirmed because these follicles then have a higher RI. As compared to the normal corpus luteum, which has an RI of less than 0.5, this is in the range of more than 0.55 most of the times, reaching even 0.6. And usually the dominant ovary would have less resistance in low resistance vessels as compared to the non-dominant ones, but when the patient has LUF, the resistance in both the ovaries are almost the same. This is a luteal phase defect. There has been a luteinization. That means there is some progesterone level. So the endometrium would be fairly normal in thickness, though the vascularity will be less. Whereas when you go to the luteal phase defect, it can be because of 2 reasons. Either the secretion of the progesterone is low, or the receptivity of the endometrium to progesterone is less. If the secretion is bad, that means the corpus luteum is not functioning normally, and that you can know by high resistance in the corpus luteum flow as compared to the normal in the mid-luteal phase. And if it is not because of the low production of progesterone, the corpus luteal flow may be normal. In spite of that, the endometrium will show you high resistance vessels as compared to the normal in the mid-luteal phase. That means if the corpus luteum is not producing sufficient progesterone, both the corpus luteum and the spiral arteries will give you abnormal flows, high resistance flows. But if the corpus luteum is producing sufficient progesterone, but the endometrium does not have good receptors, enough receptors for the progesterone, the corpus luteal flow will be normal, but the endometrial flow will be abnormal. The Doppler therefore plays an important role to understand the hormonal changes occurring during the menstrual cycle and plan the treatment protocol. And volume USG, if you can use them, it would definitely add.